Okay, well, that's a couple of minutes, and we've got a good number of people on the call this morning. So, firstly, a massive welcome to everybody who's joined the call this morning. For those people who don't know me, my name is Chris Green. I'm the head of operational informatics for the Emergency Care Improvement Support Team here at NHS England. I'll be joined by my colleague Paul Bullard in a couple of minutes' time. So the session this morning, we're just going to be going through two of the main products that we have available that have been developed by Paul and myself. It's not meant to be an exhaustive run through of everything, and we also have a number of other products and services that we offer as a team as well. If people would like to know a little bit more about who we are and what we do, please feel free to get into contact with us and we will go through this. Paul's going to be going through the ECIST UEC dashboard for around about 40-45 minutes. We'll then have time for some comments and questions. We'll then have a couple of minute break as well, just so that people can use the facilities or go and get a drink. And then I will be going through the updates to the SAPIT dashboard that many of you will be receiving as well. So I hope that's okay for everybody. I hope you get a lot out of the session. We really do value any people's comments, feedback, or in fairness as well, when I say about feedback, it's about how you use the products. And if you would like to include anything else, one of the things that we've been really benefiting from over the past 12 to 18 months is people have been saying to us, wouldn't it be great if it could do X, Y, Z? And actually, we are not the absolute experts around this particular type of area. And actually, if you would like to see anything or would like to see any other measures, please let us know and we will take a look at including those. Obviously, we can't include everything for various different reasons, but we really do like to receive any comments or feedback you might have. So I'm just going to hand you over to Paul now, who will take you through the ECIST UEC dashboard. Thanks, Paul.
Good morning, everybody. Paul Bullard here with the ECIST team. Sorry, we're actually together. We're sitting in the same room and we're trying to kind of juggle a couple of bits of tech. So can I just get a quick thumbs up if people can hear me okay? Brilliant. Perfect. Thank you so much, everyone. Okay, brilliant. So yes, as Chris kind of alluded to, I'm going to take you through one of our key products that we produce, the UEC dashboard. Just before we jump headfirst into the dashboard, there's a couple of little bits and pieces that I wanted to take you through and to kind of set the scene a little bit for the dashboard. So within the UEC dashboard, we combine a number of different data sources in a way that I think is quite novel for NHS England potentially, but it's a really nice way of getting a really big overview of lots of different bits of data that providers submit up to NHS England and may not necessarily be fed back in a particularly useful way. So what we try to do is bring as much of that information together as possible. So there's kind of 5 key bits of data that we use, or 5 key data sources that we use when we provide the dashboard. So the first one is the UEC daily SITREP that hopefully lots of providers will know about, and it contains lots of information around your urgent and emergency care data. It also includes some bits on your beds and things like that. So we bring all of that data together. The second bit that we use is the weekly discharge SITREP. And this is I've kind of highlighted this as it's quite important because the discharge SITREP is collected at a weekly level. So we don't get the daily level of information that we do get for other bits of data sources. So when we look at we'll look at the discharge kind of dashboard that we've got within the UEC tool that we provide, it runs on a slightly different time frame. So it's just, I wanted to get that out there straight away because it can be quite confusing at times. So it's just important that we really highlight what's the kind of the time difference there. We also use the COVID daily SITREP to get some of your COVID information. It's not gone away, unfortunately. There's still plenty of COVID kicking around. So we report some of those figures. We are starting more and more to use the emergency care data set, which some people may be aware of. Essentially, this is a kind of a patient by patient record of interaction with the emergency care kind of system. And we can use this and we can kind of delve into a little bit more detail than we can do when we look at some of your summary SITREP data. There's still kind of questions around some of the data quality within ECDS, and that is being kind of monitored elsewhere. But as we kind of grow in confidence with that, we'll probably see more and more bits of metrics and of data that we can feed into this main dashboard. If you kind of there's bits and pieces that people find interesting or useful to be able to review as frequently as we do. And then the fifth data set is the ambulance daily SITREP as well. So some of this information used to come through on the UEC daily SITREP, but we can actually now tie into some of the information coming from the ambulance services that they submit. And that helps us with things like handover times and kind of average delays and things like that, which is hopefully kind of really quite informative and quite useful for people. The dashboard, because of the way that it's built and the way that we operate, we look at the last 120 days worth of data. So there's quite a big chunk there, and hopefully that's kind of quite a nice recent and relevant period for people to look at. But that's the kind of the extent of the data that we can look at within our dashboard. The last little bit before we take a look is to say that we circulate this twice a week. So we do it on a Monday and a Thursday, and they will cover data up to the Sunday or the Wednesday, depending on which version it is. So we get, it's all quite recent and relevant, but hopefully it's a really useful tool. And the last little thing, I guess, the second last little thing to say is that if you don't already receive it, because I know that we've had a number of people kind of request to see it, and if you don't currently get it, if you just pop your email either in the chat or come out to me at paul.bullard1@nhs.net, and I'm sure Chris will put that in the chat for us as well. We're more than happy to get you added onto our distribution list. It currently goes out to about 3,500 colleagues across the NHS, and so there's a good kind of group of people, and there's probably people in your organization that already receive it. If you would like to receive it yourself, do just let us know, and we are really kind of liberal in sharing this dashboard out with people. So hopefully that's the kind of the boring bit out of the way, and now we're going to talk about some data. So I'm just going to quickly stop sharing my presentation and start to share the dashboard. So bear with me. Okay, I can see that that's coming through okay on Chris's screen. So we'll get started. So we produce different dashboards for different kind of super regions, I guess is the way to think about it. So we cover one for the South, one for London, one for Midlands and East, and one for the North. And within those, if you want to look at, because we know that we've got colleagues from kind of different organizations, from regional colleagues to ICB colleagues to kind of down to site level colleagues, actually you are able to cut this data in lots of different ways. So by just using this selection at the top here, we can view it so I've got the South open as an example for the Southeast or the Southwest if you're a regional colleague. If you work within an ICB or you're interested in your ICB's performance, you can cut it by different ICBs. If you work across an organization that might have multiple sites, you can look at this data by trust. Or actually, if you work just at one site and you want to just see your own data, you can actually cut it down to that level as well. The one proviso with that is that the discharge SITREP is collected at a trust level, so we can't cut that down to site level, but we can aggregate it up to ICB or region level. But it's just worth again saying that the discharge SITREP is a slightly kind of different beast to some of the other data sets and sources that we use. So it's only available at a trust or a higher level. So that's like I say, that's the boring bit, right? So let's look at some data. So the first kind of thing that you will see with a dashboard is kind of what we call kind of like the metric grid. And I often say that this is the only bit of the dashboard that's going to give you some solid answers. The rest of it was just going to pose some questions. So what I mean by that is, or what this is showing us is, for kind of 16 of the key metrics that people are looking at or are interested in, we show you what the performance or the data is telling us about your trust or site or ICB or region, what's telling us about what's happened in the last kind of week in comparison to the last 6 weeks as an average. And so we cover lots of different things here. So we've got kind of things like attendances, 4-hour performance, we look at bed occupancy, we look at available beds, we look at your ambulance handover information and your long length of stay. So lots of different bits here, but it's a really nice kind of quick elevator pitch as to what's happening within your kind of your UEC system at that given time. And some really important, or some really kind of quite interesting things that we do. So hopefully lots of people have heard of or have used an SPC chart before. We actually apply some of those rules that you use when you're looking at an SPC chart, and we apply that to that data to give you a nice kind of quick view of, okay, so what's actually happening with the data. So we cover 4 rules. So rule 1 is if there's a point outside of the upper or lower control limits. 2 is 9 points above or below the average. Rule 3 is 4 out of 5 beyond kind of 1 sigma, so within that kind of the unexpected range. And rule 4 is 2 of 3 beyond 2 sigma. Again, for those that have done SPC, hopefully that all kind of rings familiar. But what we can do is we can see where we have kind of unusual things happening within our data. If it's a green diamond, it means that it's happening in a positive way. So, for example, across the south, the 4-hour performance in all types has seen a data point outside of our control limits in a positive fashion. So we can see that, okay, actually our 4-hour performance is improving. And so that's highlighted with that green diamond. Whereas actually for our long length of stays, we're seeing some rules being broken in a negative fashion. So actually, you know, in the context of long length of stay, it's probably that they're increasing. So we're seeing some black circles. And again, it's just a nice way to really highlight kind of, okay, are we seeing improvements or are we seeing causes for concern within our data? And so that's a nice kind of quick overview. And it gives you, like I say, some of the answers, but there's probably some more interesting stuff we want to do with the data. So the next step then in our dashboard is to look at some ranking. And now we don't really like ranking, but we know that people look at it. So we can rank some of our performance, our 4-hour performance across organizations. So we look at the kind of your 4-hour performance with all types, your type 1 4-hour performance and your type 3 4-hour performance. And actually, if we select a random trust, we've got Dartford there, what it will do, it will highlight that particular organization within there. So you can see, okay, where do we sit regionally within our group? And we also provide a national ranking as well for each organization. And that will obviously, that will depend on the trust that's selected at the top here. So I don't want to spend too much time on ranking because we don't really like ranking. It's not a great way of measuring individual performance, but it's there if you want to kind of see where you sit regionally or nationally. So much more interesting, our SPC chart. Now, again, I won't kind of go through exactly what an SPC chart is or how it works or how it's kind of built, as there's loads of stuff out there and lots of people are using SPC charts as it is anyway. But this is nice because we have a list of about 60 different metrics that you can really quickly and really easily pull out into an SPC chart. So just to give you some examples, we have kind of our standard 4-hour performance metrics that we look at. We have our 12 hours. We then also look at things like your bed occupancy, ambulance handovers, attendances, your like I say, your bed, some of your COVID information, if you're still looking at that. And then this is where we start to bring in some of those other data sources. So what we've looked at so far is a lot of the the UEC SITREP stuff. But actually, if you want to look at your percentages of discharges after 5 p.m, okay, what does that look like? How does that look over the last 120 days? We can look at that. We can look at your long length of stays, the number of patients with no criteria to reside, your ED occupancy at midday and midnight. So there's lots and lots and lots of different metrics in here that you can have a little look through and have a little scroll through and see, okay, what are we kind of interested in? What do we think is of use operationally for us to measure? And are we seeing some of those periods of improvement or periods of concern that we want to kind of dig into a little bit more? And again, like I say, there's no real answers necessarily here, but this is a really nice way of posing some questions. Similar to what you might have seen in other SPC chart tools as well, is that if you've done a particular period of improvement and you want to see, okay, what impact did that have, you can actually select a couple of dates. So let's say we tried to do some sort of improvement for our 4-hour performance between the 13th of November and let's say the 27th of November. And actually we can see there is a slight change in our control limits there. If I zoom in, perhaps it might be a little bit clearer. So what it will do, it will recalculate your control limits for that particular time period. And if there's kind of any changes there, they'll be highlighted. So again, if it's one of those things where we're making these dates up at the moment, it's not particularly showing anything. But if you have done some sort of improvement event to try and improve one of your metrics, actually this will show if you have had a kind of a difference or made a difference. So the SPC chart tool, like I say, it's hopefully kind of lots of people are starting to use them more and more. And this is just a nice kind hopefully easy way of showing lots of different metrics. And the SPC chart is built for you already. All you need to do is go in and have a look and see what's of interest to you. Okay, the next part then is a very it's quite complicated, but it's a really powerful tool. And I can't take any credit for it. This is Chris's idea. But essentially, if you try to compare different metrics that are of either different scales or are of different units. So, for example, if you're trying to compare a percentage against a count, it's quite difficult to put that into any sense. So what we have here, we call the metric comparison graph. And essentially what we do is we take 6 weeks worth of data and we say, okay, what was the average for that data? And how does our data move around that average over time? And what this allows us to do is to compare metrics of different kind of scales and of different volumes together in a nice kind of easy to interpret way. So again, I'm just going to zoom in slightly. And I've selected, so all of those metrics that were in the SPC chart can be selected here as well. So you can compare lots of different things together to see where there's some interaction. But we're looking at our 4-hour performance, the number of beds that are occupied, the number of those beds that are occupied by long length of stay with 14 days patients, and then also our time to treatment percentage. So when we combine those 4 metrics together, what we can see is that as things like our number of beds occupied increase, and as our 14-day length of stay patients increase, we can see that our 4-hour performance is kind of decreasing. But particularly relevant here is our time to treatment. We can see that really starts to suffer as some of these other metrics increase. So it's just a really nice way of comparing different metrics together and seeing kind of how that they seem to interact. Now, I wouldn't go as far as to say that there's causation, but there's certainly correlation between some of those metrics. And again, it's about not necessarily providing an answer, but allows you to question, okay, so what was happening in this period, particularly in this example, kind of in that first week of February, what seems to have been happening where some of our metrics have suffered, and the impact that that has on some of our other metrics as well. So again, it's a really nice way of viewing lots of different things together in potentially a way that you might not have done as of yet. Very kind of similar, and one of our new additions that we're starting to roll out on our dashboard. We can do a bit of a kind of a scatter graph of a couple of different metrics, and this is really useful for when you have kind of a dependent variable and an independent variable. And what I mean by that is when you want to look at, okay, as something increases or as something changes, what happens to something else? And again, it's not causation, but again, it's just a nice indicator of correlation. So in this example, I've picked out two of the metrics. Again, all of the ones that are on the SPC chart are available. So as our x-axis, we've got our number of beds occupied, and as our y-axis, we have our time to treatment. So what we're trying to identify is, okay, as our number of beds occupied increases, what happens to our time to treatment percentage? And you can kind of get a view of that from here. So obviously, as it seems to be increasing, we see a slight kind of slope downwards in our time to treatment percentage. And that's like okay visually, but what we do also provide is this correlation value. Now this runs from -1 to 1, where 0 right in the middle would indicate there's no relationship between those two variables at all. So as beds occupied increases, if it was 0, we would see no change in our time to treatment percentage. What we're actually seeing though is this negative number. So what this is saying is that as our beds occupied increases, our time to treatment percentage decreases. And -0.5 is one of those kind of values where it's like, well, kind of, but not really. So the closer to -1, the stronger that relationship would be. If actually it was the other way around and we were looking at something like as our number of attendances increased, what can we expect? No, that's not the right. So it's difficult to think of one off the top of the head. But if there was one where, you know, you kind of expect as something increases, something else to increase, that would be closer to a +1. So again, it's just a nice kind of view. Again, we're not saying it's causation, and we're not saying that the beds occupied definitely increases the time to treatment, but it is a measure of that kind of correlation between the two variables. What you can also do, if there's particular days that you are interested in, you can highlight different days on the chart, and it will highlight, okay, so what happened on the 29th of November, for example, here's our value. So you would read it across X and up Y. So again, just a slightly different way of looking at some of this data that you may not have seen so far. And it's a nice way of bringing in metrics from lots of different places. So, you know, you can look at what your discharges look like in comparison to some of your data from your UEC SITREP, for example. So it's just a nice kind of way of bringing together lots of different data sources. And that's kind of the main part of the dashboard. Now, there's a couple of other bits to take you through as well. So we have a sheet down which looks at specifically some of your occupancy information. So we look at things like your bed occupancy, your 7+ length of stay occupancy, and as a raw number, and then your 14 and 21, the number of beds occupied by COVID, and that number. Again, a bit of a kind of an issue of the discharge sit rep only being weekly. On a Monday, these values will be populated with the number of beds occupied by patients not meeting the criteria to reside. We've taken it out of the kind of the Thursday circulation just because the numbers and the weeks don't match up. But like I say, on a Monday, you'll get a good idea of how many beds are occupied by patients not meeting the criteria to reside. And again, we then look at those discharges on a Monday version. You'll be able to see your discharges for the previous week, before 5 and after 5, which is all that data that we collect on the discharge sit rep. That's kind of the extent of that. It's kind of a little bit being superseded by other parts of the dashboard, but it's still there for people to have a look at, and people still enjoy, or enjoy might not be the right word, but still value this view as well. But at the moment, it is being superseded by other parts of the dashboard. The next bit then that I'm going to take you on to again is another recent development on the dashboard, which is a view of the discharge sit rep. So this will be controlled by the selection that you make earlier in the dashboard. So if you selected a particular organisation, it will show here. Again, the caveat that if you have selected a site, this data, it won't work because we don't get the data at a site level. But if you've selected an organisation or an ICB or a region, it will give you that overview of the discharge sit rep. And like I say, this is data for week ending the 25th, which was the Sunday just gone. So it's on a slightly different timescale to the rest of the dashboard. It's just the nature of the timing of the data. But what we provide here is that feedback loop from the discharge sit rep to say, okay, this is kind of some of your discharge information that we are receiving, and here's kind of what it looks like. So there's a number of different kind of sections of this. So this is the kind of the weekly summary. So we look at things like the reason that people have a criteria to reside, so for treatment, recovery, physiology, or function. We then look at the average number of patients per day that have the criteria, have a criteria to reside. How many of those, how many don't have a criteria to reside? And then we start to think about, okay, so how many of those were not discharged and how many were discharged? So again, it's just feeding back some of that information that we get from that discharge sit rep in a slightly different view to what you might have seen previously. Of those patients criteria to reside, how many aren't discharged as a percentage? How many are discharged after 5 p.m. and how many are discharged by 5 p.m. And again, that will react to the organisation that you might have selected. Of those patients that have either a 7 or a 14 or a 21 long length of stay and no longer meet the criteria to reside, how many additional days in hospital do they have as a kind of a cohort? And then we start to look at some of the pathway information as well. So which pathways are patients going down when they are discharged? And then that breakdown of that pathway. Okay, and where are they actually going? Are they going to home? Are they going kind of somewhere else? Are they going to care homes or rehab beds? So again, it's just a nice kind of overview of some of that information that's being sent through on the discharge sit rep. Now, this is then kind of, okay, so of those patients that are kind of delayed, why? And this is a really useful tool when you're working with kind of other providers or other systems within your kind of your area. Okay, so why are some of these patients being delayed? And you'll see for most organizations, there's a kind of a pattern that emerges where it's particular pathways or particular reasons really stand out consistently week on week. So again, this is all from your discharge sit rep data. So it's things like pathway 2, waiting availability of a rehab bed in a community hospital, pathway 1's and down through things like no plan, all that sort of stuff. So loads of information, and it hopefully it provides lots of kind of information and data for you to go out to others and kind of say, okay, look, this seems to be a consistent problem. What can we do to try and kind of remove some of these delays? Because we know that kind of delay at the back door is a huge pressure on the front door. And that's quite nice as like your kind of your weekly summary. But then we do also trend some of this data out. So again, there's a lot of kind of data and charts and graphs in here, but I'll take you through them. So we trend out some of these kind of criteria to reside metrics. So those with the criteria to reside by reason, those with as a total, those without criteria to reside as a number, the percentage of your patients that have no criteria to reside, the number of patients discharged by or after 5 p.m, and the percentage discharged by 5. So again, lots and lots of information for you to kind of to dig into and have a look and see, okay, what are we seeing in terms of trends? So we're seeing, for example, we're looking at our percentage of our patients with no criteria to reside across the South in total for here. So we can see some of that trend over time. It's pretty flat in this example, but you know, if there's something going on, it will help identify that. We then look at your kind of your discharges by pathway. You'll see that in a lot of these, there's kind of exclusionary options here, just because pathway 0, for example, is massive in comparison to the rest of the pathway, so it just swamps the data. So there's the opportunity for you to kind of to filter through some of that kind of that noise to pick out what's interesting to you. Your discharges by destination as well, that's all in here. Your discharge destinations for each pathway, so you can select different pathway. Okay, where are our pathway 0 patients going, or pathway 1, for example. And then those similar in a similar way, these delays that we were looking at here, okay, what does that look like over time as well? So we can see where, if we are trying to make improvements, if we're having an impact. So again, some hopefully some really interesting data in there for you. The last little bit that's very interesting to a lot of people is that kind of that difference between the discharge profile on a weekday versus the weekend. So again, we provide that information for you. So the number of or the percentage of your total discharges, what day are they happening, and what does your weekday versus your weekend average look like? So again, not necessarily giving you answers as to what to do, but it will certainly help kind of have informed discussions about what's happening with your discharges. And so that's fairly new. So if there are comments or questions on that, in particular, we'd be really keen to hear how we can potentially, you know, either do this better, or if there's something that we're missing that would be really useful to see in this view of the discharge information that we have. And again, I can't take any credit for this. This is a Chris Chris idea, but this is a kind of what we wanted to do was show like a one-pager that I'm going to say it, but you might want to print out and display somewhere. On some of the key kind of metrics that the dashboard looks at, and we've had some really positive feedback on this. So we're really keen to hear from people if they are using it or if they have ideas or suggestions for it. But essentially, what this does is that we know that the dashboard is really interesting, and it's really extensive and there's lots of stuff. But if you only had 3 minutes to talk to someone about, okay, what does our UEC system look like? What is going on in our hospital? This might be a good place to start. So we track through in a kind of a very specific and a designed way. So we think about, okay, with our ambulances, how many people are coming in? What percentage of our attendances are via ambulance? Where are we seeing handover delays? And what sort of time are we looking at? What is our average handover time for our ambulances? We know that obviously that's a huge kind of point of pressure at the moment. Our attendances, okay, so we know how many are coming in via ambulance, how many are coming in via walk-in. Where are they coming in? What type of department are they coming into? Are they coming into our type 1s or into our type 3s? How busy are our departments at different times of the day? How busy, how many people do we have occupying EDs at midday, and how many do we have occupying EDs at midnight? What are some of these key time and department metrics looking like? So how many people are we seeing within 60 minutes? What's our type 1 performance looking like, and what's our total performance looking like? And then as we start to move through, okay, how many admissions are we getting in? How many are coming in through A&E, and how many are coming in as emergency admissions from other sources? What's our conversion rate look like? How many patients are we converting from our ED? And then our beds. So what's our our bed occupancy figure? How many escalation beds do we have open? And then how many patients are staying for 7, 14 or 21 days? And then the last little bit then is our discharges. Okay, so how quickly or how effectively are we discharging patients before 5 p.m? So again, it's just a really kind of simple look at some of that really complicated data that you can kind of dig into, but actually this is quite a nice summary view of what's happening within your organization or your region or your ICB. So again, it's just a hopefully quite a nice overview of what's happening. That's kind of the data. There's a last couple of little bits just to flick up and flick through. So as we are starting to make more and more changes to this, as we're starting to build on this as much as we can, we are starting to kind of track some of these changes. So as we add things in, so we're adding breaches by type to SPC metrics, we're starting to log and keep a bit of a control over what is coming on. So if you you look at something, you kind of think, oh, I'm not sure where that's come from, it'll be listed out in here for you. And the last little bit that I'm still working on, because there's lots of different metrics that we use. I've started to put some of those data definitions in. Like I say, at the moment it's not complete, but I am going through it as quickly as I can, and hopefully this will just give some of that overview of, okay, we've got we're being presented a number, but how has Paul and Chris, how have they got to that number? So hopefully we can kind of spell out exactly what we've used, where it's come from, and if there's any sort of calculation that we do on it, how we calculate it. So we are listing these out for, like I say, all of the different metrics that we use across the dashboards, in all of the different sheets as well. So if you have any kind of thoughts or questions on where a particular number has come from, you can just jump to our data definitions and it will give you a bit of an overview of how we've got to a particular value. And I think for now that is it for the dashboard. I can see Chris has been typing away furiously, so I don't know if you want to start sharing some of the questions, Chris.
Yeah, I've been trying to keep up with all of the with all the comments and questions and suggestions. My typing skills are not great, so forgive me for not doing that. I think the best thing that we're going to be able to do is, I'd like to take any comments or questions that people would like to actually go through now. We will go through all of the questions that have been posed on there. I'm conscious I've not been able to answer all of them, so I do apologise. But there've been some really fantastic ones in there, some great suggestions. I think the key one for me is a lot of it is around the visualization, and so if you change one element of the dashboard, does it feed through? And the answer is yes. So Dave, I know from you spoke about your question was around about the infographic, and Could it be done at a regional level? So if you make whatever selection you make on the dashboard page, it will filter through. So if you select a whole region, it will feed through the whole data, so the SPC chart, all of the other charts. It will also feed through into the infographic. If you make the change to an ICB, a trust, a site, you can do all of that, and the data will automatically feed through. So there may be a few changes, and I think one of the and I've tried to be relatively diplomatic around this, is around the data and whether things are quote unquote missing or not. You know, Ema, you said about it doesn't feel operationally real. The only thing I can say about that is, contrary to any belief that people may have, we don't make this up. The data that we use for this all comes from you guys, comes from each individual provider. If there are issues around that, we are happy to help you out. Okay, absolutely, but it's not a prerequisite. We don't want to tread on people's toes. If you think something is wrong or just doesn't feel right, and the best people to go and speak to are your information colleagues, call them what you will, analysts, BI people, whatever. Go and find them out and find out A, where they get the data from, and B, what they do with it. Okay, because there may be some subtle changes that are made, which takes it from what you feel is operationally real and what the technical guidance of how they should submit that data. So there's a real big difference around that. So please feel free to go and do that. I think the next thing is I'm just going to open up the floor and see if anybody has got any burning questions that they would like to ask Paul regarding the dashboard that people haven't put on the chat. Yeah, Dean.
Hello, can you hear me? Yeah.
Yeah, we can, Dean. Yeah.
Sorry, struggling to get off mute. It was just around the infographic, really. I did put it in the chat, but I think I just need clarity for the team as well, because we do use this. So looking at the attends based on what we know MFT have on a weekly basis, I just need to confirm that these are based on weekly averages for the week. Because looking at the numbers against the MFT numbers, if it was a weekly one, we're looking around 9,000, but looking at the attendances that are on there, it looks like they're based on an average. And if that's the case, I think it needs to be labelled as such so people are clear of what they're looking at.
Okay, yes. So it is it's which organisation was it? Sorry.
MFT, Manchester Foundation Trust.
Okay, so I don't have it on here. So let me just drill down to a particular organisation. I'm not going to use Dartford again. We come in here. So this will be, yeah, so it will be a daily average. So I will take that on board. Yes, I'll make it a little bit clearer as to what we are looking at here. That's absolutely fine.
Yeah, no worries. Thank you.
No, thank you.
Yeah, no, thanks very much, Dean. I know, Nat, you mentioned around the occupancy. So I think what Paul mentioned though was around the data definition. So on both the ECIST dashboard and on the SAPIT, we now have data definitions so that you can go in there and say, right, what does that actually mean? Because we can try and explain it, but we may stumble over our words just because we're data people and we try and use the English language to our full extent and sometimes fail. But thank you very much for that. And thank you very much for everybody's comments and questions. It's been really, really helpful to see. Thanks. Emma?
Yeah, I just wanted to clarify the RAG rating, the green and the yellow and the red in the chart there for the long stay patients. That is RAG rated, isn't it, against target? So if it's showing green, it means you're meeting the long stay targets.
Sorry,
that one.
I don't know
Yeah.
if you can see me. Yeah. So no, that's not set against any target whatsoever. That is just a visualization.
Right.
I've done it kind of red, orange, and green just because that seemed to make sort of sense. So it's not against any target at all. It is just it's just a raw figure of what is your proportion of long stay patients.
And is it not possible then to put it against the targets? Because obviously we are being measured and pushed, aren't we, towards the no criteria to reside and having our less than 10%. And this all adds to that, doesn't it? Long length of stay. I just think it'd be really good from an infographic. I love this new chart, by the way. Thank you for all the work you've done on it. I think it's come such a long way from just a spreadsheet, which is not my preference. This is more my preference, to see it in a nice picture. So thank you. It meets all different styles, doesn't it? I just feel if we had some of the targets on here as well, it would be quite nice to see that RAG. So when we're visualizing it and we're showing it to people in whatever forum we're showing it in, it's really clear this is our performance because we've got it down to trust level, but this is where we're performing against the actual national target. You know, even if it's just a line across where the percentages are, you know, it doesn't matter then what colour it is, does it?
Yeah.
You know, just something to show us. Similarly with ED performance, yeah, you're performing at whatever percent, but actually the target is this, so you can see where you are off it. Because it just focuses the mind, I think, then, doesn't it? And we do, on that page, there's lots of targets there that are national targets, and it'd just be nice to show them. And on the discharges one, I also, I do like it. I do love the little graphs of the extra graphs underneath the criteria to reside matrix stuff. But it's just a lot of squiggly lines, isn't it? I just wonder if there's a way we could show any linear trends. You know, is this actually quite static, even though it's going up and down, or are we on a downward trend? Are we on an improving trend? You know, a bit like we do with some of the others, where you have your dots, your concern areas of concern. You know, the other NHSE ones with the dots on. That would just be, again, I just think, again, if I'm going to use that, if I was to cut and paste that into a PowerPoint presentation for my UEC group, for instance, it just looks like a squiggly line, but I'd be able to show them actually we're doing well, or we've got some areas of concern. Yeah,
brilliant, thank you. Yes, and we can certainly look at how we, like I say, this is so new at the moment that we're really keen for that sort of feedback. So really appreciate it, and it's certainly something that we can look at doing.
Yeah, and as slightly ironic that I'm colourblind, but I shall ensure that those colours are changed. It's a fantastic Freudian slip, using red, amber and green for an area where there are actual targets. So we will take that one on board, Emma. Thank you very much. We like to do this to make it, you know, we like to shatter people's illusion that we are perfect. So that's just the way it goes. Thank you very much, Emma. Charlie, you had your hand up.
Can you hear me, first of all?
Yeah, we can hear you.
Listen, I was just on that point. You know, it's interesting, isn't it? The no reason to reside stuff. What we've done is we've weaponized that, like we did with the discharge to assess. Sorry, the delayed transfers of care. I think the process is the process and what we're trying to do with the no reason to reside stuff. I absolutely 100% agree with. I know that we've completely screwed up no reason to reside within our trust. I think the data is appalling that we're collecting. We're certainly not collecting it at board rounds. So I think there's just a rule of thumb here, and it's probably an ECIST message, isn't it? Whilst we might have targets, actually delivering safe and effective care, if the rule of thumb is we shouldn't have no reasons to reside. Yeah. We shouldn't have many people staying more than 7 days.
Oh, we've left you on an incredibly profound point, just saying we shouldn't have them, which I think we can all agree upon. But hopefully, Charlie, you'll be back relatively soon. But thank you, Charlie. And I know Paul met with you guys yesterday to talk about your data, and I think that was great. Just to echo the point I was talking about a few moments ago, was just around the fact that the data that we use does come from each individual provider. If you have any issues around that, please go and make sure that you contact your BI teams, because as you were talking about, Emma, you know, if people are looking at this, and people are looking at this, we need to make sure that data is technically right, but also operationally feels right as well, because you know, I'm not a big fan, and I'll be talking about it when I go through the SAPIT dashboard later on. I'm not a big fan of these kind of really crude measures. Crude measures happen for a multitude of different reasons, and we need to understand those reasons so that we can then work towards the improvement journey. And that's why these dashboards, these two predominant tools that we have available and that we send out to you guys, have been well received and are being used on a frequent basis, which we know about. Does anybody have any closing comments or questions for Paul? Or if not,
Stunned into silence.
Stunned into silence. But can I just want to welcome somebody who I haven't seen for a number of years, and I used to work with down at my old provider, and it is lovely to see that person who has just joined on the camera. So it's lovely to see you. So what we're going to do now is we're going to take a short break, just so that people can go and get use facilities, or go and get a cup of tea or your drink of, or whatever you want to do. Probably a little bit early for a gin on a Friday morning, but maybe it might get you through my session in a few minutes' time. So what we'll do is we'll take an 8-minute break, if that's okay, just to make sure that everyone's got time for that. We'll come back at 1:30, and I'll be going through the SAPIT dashboard and some of the significant changes that have been made to that. Like I said, if people have to drop off, that's absolutely fine. We will be recording this session and make sure that everybody gets access to the recording. So we will see everybody back, hopefully, at 10:30. So the SAPIT stands for the Summary Acute Provider Indicator Table, and there's three main questions about why I kind of created this. So around, it's been going now for probably around about 2 years, something like that. What is it? Well, it's a dashboard that looks at multiple metrics across the UEC pathway. So I was really acutely aware that there are loads of dashboards. Okay, if there's one thing the NHS has got is data. But actually, we need to put it in a really meaningful type of way. And the other thing that I was quite conscious of is that people are really busy. So have they got time to keep going on and remembering their login for this particular dashboard and that particular dashboard? And we've got one for acute medicine, we've got one for ambulance, we've got one for discharges. You know, why should you have to go and have a look at multiple different sources when you could get a broad view of what is going on across your UEC pathway? It also takes the data and applies it in a very similar way. You'll understand it by the naming of the dashboard around the sister products, which are kind of the SEDIT and the SAMIT now as well. So the Summary Emergency Acute Medicine Indicator Table. And it's a way in which that we can look at the data, once again, that is provided from each of the providers. And I'll go on to talk about some of the data sources in a minute, because it's slightly different from the ECIST dashboard. But it's a way that we can apply some sort of national comparator to the data that is provided. I think I just want to kind of just re-emphasize, though, around this is that, and it was something that Paul really quite rightly said, and that's, it won't necessarily answer all of your questions, but it will provoke more discussion around what the data's saying and why it's saying it. And I'll just kind of pick an example, because what we're doing in here is we're almost applying a blanket position that every hospital in the country is exactly the same. The type of patients it looks after are the same. The type of services that it offers the same. The different services that the system provides are exactly the same. And we just frankly know that that's not the case. However, we need to kind of start off from a relatively simplistic position and build up the layers of complexity so that we can answer those questions. The reason why we built the SAPIT dashboard was from some of the comments that were put into the chat. Actually, we wanted frankly, that one of the things was we wanted a longer time series to have a look at. So the UEC dashboard is meant as a relatively short to medium term improvement analytical tool that we can have a look at what's been going over on the past few weeks, the past few months, and looking at it in terms of daily data, a little bit more performance-y. But actually, if we want to kind of have a look at different improvement levels actually looking back at monthly data from a much longer time period, and we look at the past 2 years, so we can really understand some of the improvement journeys and some of the fantastic improvement that we have been seeing. And you know, it's very easy for me to say, as kind of an analyst and particularly someone that works for NHS England, is that there have been fantastic pieces of improvement that have been going on in different systems, different providers, across a multitude of different areas. So really trying to be able to evidence that is an absolute fundamental reason why we have tried to build these products. We also wanted to try and to utilise different data sources. So Paul really ably described some of the data sources that we've been using, but there's loads more. Okay, as I said, the NHS is awash with data. We really need to try and understand what the data is, where it comes from, and what it can be used for. And as we go through this session, I'll try and talk through that as well. It's produced on a monthly basis. At the moment, it is based on a month in arrears data, and the main reason for that is that when we look at things such as A&E, we've got data right up to yesterday. Okay, you guys submit on a daily basis what has been happening yesterday. But from an inpatient perspective, SUS, and I'll go on to talk about that in a minute, is always a month in arrears. So actually, we do have to have that time lag to understand what has been going on. And yes, there are things such as faster data flows, and we do know from some organisations what's been happening in terms of inpatients up to yesterday. That's not always the case. So at the moment, the data is a month in arrears, but as I said, it's not really meant as a daily performance dashboard. It's meant as an improvement tool, which is why having something that's a month in arrears is not necessarily something significant. If we then go on to have a look at some of the data sources, so many of them will be very, very similar to what Paul described earlier. The UEC SITREP, the discharge SITREP, the ambulance SITREP, one of the other 5,000 SITREPs that are provided by organisations on a daily basis. But we also use things that are submitted in a slightly different way, so using the emergency care dataset, otherwise known as ECDS. And from an inpatient perspective, we also use secondary usage services, or otherwise known as SUS. It's also important to understand that we don't use kind of hard evidence data. We also use things such as primary care survey data and NHS staff survey, because from a piece of work that I did, I don't know, a few years ago now, it was really apparent that organisations who struggle with performance, and if we just focus on performance just for a second, organisations that significantly struggle with performance also have really bad results in terms of staff surveys. So particularly around some of the negative questions around, I look forward to going to work, my line manager listens to me, we have enough staff at work. Organisations that significantly struggle around performance also have poorer outcomes in terms of staff survey results. And then using primary care survey data, we can understand what has been going on in terms of how the population perceive primary care and what that might mean to the acute setting. So, for example, if people are dissatisfied with their booking of primary care, the overall experience of primary care, guess what? They are more likely to then go and say, well, actually, I think I want a second opinion, or I can't get access to my primary care activity anyway, therefore I'm just going to go and see a clinician in an acute provider. So using these different types of data really allows us to have a look at data in a slightly different way. So I'm just going to go and now have a look at the actual SAPIT dashboard. So hopefully people can see that. And we are going to have a look at Hospital A. So the SAPIT dashboard is only available at the moment from a site perspective or from an ICB perspective. It is not available at a provider level. It is not available at a regional level. The reason why I've only kept it at a site and an ICB perspective is that particularly from a multi-site acute provider, if I worked for that acute provider, that's fine that I might have 3 hospitals, 4 hospitals within my acute organisation, but actually they might be so different that they are masking each other's challenges or areas where they are performing quite well. So therefore, I'm not a big believer in provider level data. I'm much more around what is going on in each individual hospital. At the moment, the way in which this is being sent out, as many people will have received an email from me last night, is that these are sent out as PDF files on a monthly basis. There was a comment in the chat box around are these dashboards going to go on to the federated data platform? Are they going to go on to Power BI, Tableau? That is something that we may look at in the future. There are pros and cons to doing each of that. And the last time that we undertook a survey around how would people like to receive this, the vast majority still said they would like to receive it in their inbox, so they haven't got to go looking for it somewhere, remembering their username and password. So for the foreseeable future, it will remain as distributed as we currently do, but this may change going forward over the medium and long term. I hope that's okay with everybody. So what we're just going to do is I'm going to take you through what the SAPIT is, what it does, how it works, some of the data that it contains. But as I said around Paul's presentation, I will happily take any comments or questions as we go through this or at the end of the session. So what I've done is I've divided the data up into multiple different domains. So once again, following a very similar vein to the SEDIT and the SAMIT, we look at different domains so that if you are interested in one particular area, you can go directly to that. The first thing to say, and picking up on, I think it was Emma, your point around RAG rating. So there are two, and I know I'm preaching to the converted because there'll be many analysts on this call, or if you like SPC, then I'm going to be preaching to you as well. There are mainly two ways in which you can look at data. There's kind of a measurement for improvement methodology, or there's kind of a benchmarking comparison. Okay, and there is room for both, and both have their pros and both have their cons. At the moment, we are using just a kind of a RAG rating methodology to this to look at where you sit, where this hospital A sits for each measure within the rest of the country, applying what I talked about earlier, that we kind of making that very large assumption that every hospital is the same. We know it's not. For each measure, you will see that they are in one of four different colours, red being the most challenged, then amber, light green and dark green. And I make no apologies about using the terminology most challenged. I know I've said this a lot of times now, but if I was working in an acute provider that was significantly challenged and not performing not at the level that they would want to, I think it's not that nice, to be fair, to be told that you are in the worst quartile in the country. They would probably know that, and they don't need to be re-emphasised by an external organisation. So actually, I imagine if this organisation is significantly challenged, I say you are in the most challenged quartile in the country. Did you know that? Probably yes. If you didn't, we're just making that aware. And what you'll see is there's loads and loads of different metrics, but actually broadly, the metrics are split into two categories. They will either be shown in terms of a performance or a growth value. The growth value will be looking what has happened in the most recent 3 months compared to the same period the year before. For a performance measure, it will be what has happened in that particular quarter. So quite different from the ECIST dashboard that Paul just described and talking about daily values. This is looking about a much broader perspective and looking at a quarter compared to a daily or even a weekly perspective. But so each measure will either be a performance measure or a growth measure, and they will each be put into the national quartiles, all apart from two different measures, which I will talk about in a couple of minutes' time. If we start off, I'm not going to go through each individual measure because the vast majority of these measures you'll be very, very familiar with. I'm not going to talk about those. I will just draw your attention to a few different measures that you may not have heard of before, and I will talk about the definitions for those as well. I know somebody put in a chat box earlier about the delay-related harm. I will be talking about that especially. So if we just kind of have a look, so once again, they're split up into domains. And what I've tried to do is I've tried to kind of put this in a kind of a bit more of a flow perspective. So starting off around primary care, moving through to ambulances, emergency department, crowding, emergency flow measures, admitted care, and then outcomes. So you can just nicely move across the screen to have a look at, right, do we have an issue at the pre-ED? Do we have it in ED? Do we have it around acute medicine or acute surgery, or do we have it around outcome measures as well? And what I'm just going to talk through now is some of the key measures. So deprivation, for example, and this is an area for me that I think we don't utilise enough, we don't look at enough. But some of the population health statistics are really, really important that we focus on the type of patients that come through our emergency department and are seen across our acute system, so that we can tailor make our services specifically for the population that we serve. So Hospital A, for example, I've decided to not talk about one individual hospital. This is a live hospital, but so I've decided not to do that. So this organisation sees a significant amount of people from a more deprived area. So for those people that don't know, deprivation is split up into deciles. I used to say split up into 10 deciles, which is a really stupid thing to say, because of course there's 10, otherwise they wouldn't be called deciles. With 1 being the most deprived, 10 being the least deprived. And the reason why this is really important to understand is that you might kind of look at it and just kind of go, okay, so this hospital sees more deprived patients. Question, does that make any difference? But actually, yes, it does. And some of the analysis that we've been showing is that patients from a more deprived area attend ED more frequently, so they proportionally they occupy more emergency department attendances than make up the entire population for that particular decile. But interestingly, that they go to ED more frequently, but potentially, and I will stress that word potentially, for issues that could have been seen in an alternative setting if that alternative setting was available. So really important that we understand, as Paul was talking about earlier as well. Yes, we can see that deprivation is quite low, but what does that actually mean? And do we need to make any significant improvement or changes based upon what the data is actually saying? We've then got some relatively simplistic measures around age, but another area, as well as deprivation, is around mental health attendances. So this will be, it's a very, very hot topic of conversation at the moment around the proportion of patients that attend your emergency department that relate to mental health. Now, this varies significantly between hospital to hospital, and later on, I'm going to show you about the quartile ranges so that you can see where you particularly sit within the country position. But actually, for this hospital, they roughly see just over 4% of all of their patients representative around mental health. Now, you can see that that is in the amber position, so that is not in the most challenged quartile, it's above national median. You might kind of say, well, okay, but it's only 4% of our attendances relate to mental health, but they disproportionately have a significantly higher length of time in the emergency department than another patient. Okay, so if you broadly group mental health patients and non-mental health patients have a vastly higher proportional time in department than a non-mental health patient. So actually, does it matter that it's only 4%? Yes. But actually, if we need to change the way and we look at it and look at around time in department. As I talked about also around the ED measures, so A&E measures relating to primary care. So we've got two measures for primary care survey data, the overall experience around primary care and also whether people are satisfied with their overall experience. Now, you can see for this particular hospital, and I should stress that the primary care survey data is only for the ICB as a whole. So this is not very specific to that individual hospital. It is a broader view around what's happening across the whole system. But actually, for this particular hospital, they do have a really low proportion of people that are satisfied with the overall experience. What I should have said as well around the quartiles is the metric will know whether high is a good thing or low is a good thing. So if bed occupancy, for example, you want that to be low. So if it's high, it will be red. With 4-hour performance, you want it to be high. So if it's low, it will be shown as red. Okay, so you can look across the whole suite of measures here and identify any measures that are shown in red, which will mean that you are in the highest quartile in the country. Sorry, should have said that right at the beginning. Another measure which is really hot off the press, and it's a fantastic piece of work that Paul has done, but it was born out of conversations that we've been having when we go out on site visits. Has been born out of conversations we've had with people, which is that as the waiting list, the elective care waiting list has grown, we're seeing more and more patients presenting to the emergency department with exacerbations of their conditions. And so one of the measures on here is now the proportion of patients attending ED whilst they are on an elective care waiting list. Now, I'm going to preempt, we're going to have a lot of questions around how that is calculated, and I'm going to leave that one up to Paul to answer those questions. But actually, it's really important that we understand this. And this particular hospital has 12% of their monthly ED attendances that are taken up by patients who are on a waiting list for some condition or another. We have done this, looked at this by specialty as well. I will stress, though, is this doesn't mean that the patient has come to the emergency department directly linked to the reason why they are on a waiting list. And I'm gonna give you a really silly example, but it needs to be explained. So say, for example, one of the main areas of growth in elective care waiting list is around ophthalmology. Now, if the patient is struggling with their vision and they have fallen over a step at home, or they've tripped up something and they have hurt their elbow, it's not directly linked, because they're waiting for an eye appointment and they have hurt their elbow. It's not directly linked, but the fact of the matter is they couldn't see that step because of their vision problems. So therefore, it is kind of indirectly linked. Unfortunately, we've got no way of knowing that through ECDS data. It's sophisticated. It's not that sophisticated, but it does, once again, as we've both described, really goes through and starts to kind of talk about some of the other questions that we should be posing through this as well. We then move on to ambulance data, and I will just kind of stop and just pause here just for a minute, because this does need explaining. So you'll be well aware about handovers, but the reason why we've split this up into two different categories is because there have been significant changes in the handovers, particularly for this hospital. So this particular hospital has seen a massive increase in 30 to 60 minute handovers. And if you looked at that one metric in isolation, if somebody presented this piece of data and I go, oh my word, have you seen the phenomenal growth, i.e. something we don't want to do, in terms of their 30 60 minute handovers? But this is where you need to move away from looking at one metric in isolation to a series of balancing measures, because part of the reason why they have seen a significant growth in their 30 to 60 minute handovers is that they've seen a significant reduction in their over 60 minutes. So actually, is it a bad thing that they've seen more patients, more handovers between 30 and 60 minutes? No, not necessarily, because they've seen such a reduction in their over 1 hours. So really important that there are lots of measures on here, but we don't just look at it in terms of isolation as well. One of the areas that has been looked at historically is around conversion rate. And so the conversion rate is the proportion of patients that attend ED and then go on to be quote unquote admitted. That does include an SDEC facility, and we're not going to talk about that just right now. But one of the areas that we did want to kind of pick up on is that what is your conversion rate for all patients, but equally, what is the conversion rate for ambulances? Because you would imagine, me being a non-clinician, that a patient has gone through multiple different gateways for not attending ED, but yet they are still there, i.e. they've been brought in via ambulance. You would imagine that the conversion rate is really high, because the paramedics have said, yeah, you need to go into the emergency department. But actually, for this particular hospital, their conversion rate for ambulances is only just under 35%. And the national average is around about 55, 56%. So, you know, over half of the patients brought in via ambulance are admitted. One of the questions that you might then pose is kind of like going, oh my word, our conversion rate for ambulances is really low. Are our ambulance provider bringing us patients that don't necessarily need to come to ED in the first place because they're not even being admitted? But actually, another way to look at it is that a patient might be being brought via ambulance because a diagnostic test needs to be performed on that patient that simply they cannot be performed on the back of an ambulance. And actually, a way in which we can look at that is having a look at the number of average investigations that is being conducted on patients being brought in via ambulance. So yes, this organisation does see a high proportion of patients that are not admitted. However, they also perform a lot of investigations. So green would, light green and dark green would indicate that we are doing an awful lot of investigations or things to patients who are brought in via ambulance. So yes, you could argue we've got a lot of patients coming to ED that are not necessarily need to be, but actually the investigations are not saying that. We've then got delay-related harm. Now, this is done off a back of work from a good friend of mine, Chris Moulton, from the GIRF team. And I'll just describe the definition for this. So this is a piece of work, a paper that was written by him, Cliff Mann, another guy I know, Professor Simon Jones. And what it looks at is it looks at the potential, and I really do have to stress that word potential, delay-related harm. Now, when we say delay-related harm, what we really mean is that patients are at high risk of mortality because of an ED, a greater time spent in the emergency department. The categorization for this is that patients need to meet two different pieces of definition. They need to be A, admitted, and B, spent more time in your department than 8 hours. Okay, so the data suggests that after a patient has spent more than 8 hours in your department, the patient is at greater risk of mortality because of that stay. So what the calculation is, number of patients over the past 12 months that have come to this particular hospital, this particular emergency department, and have A, been admitted, B, spent more than 8 hours in the department. And the ratio is that 1 out of every 72 of those patients are at high risk of mortality because of that length of time in the emergency department. So for this particular hospital, that is 172 patients that are at high risk of mortality because of the criteria that I just described. There is the definition later on as well, but I just wanted to know that multiple people have mentioned that. I just wanted to go through that in a little bit more detail. What you'll also notice is that is not RAG rated. There are multiple reasons for that. Two mainly. One is, I don't think that we should be talking about the potential risk of mortality in terms of a good, bad, indifferent. I just don't think that. Maybe I'm wrong, but frankly, apologies, but this is my dashboard, and I'm pulling rank, so it's never going to be color coded. And equally, because we've shown it as a number, you couldn't directly compare a hospital, an emergency department that only sees 120 patients a day with an emergency department that sees 500 patients a day, because the numbers just are not comparable. We could look at it in a slightly different way, and you could kind of say, well, at 172, let's just divide that by the average number of daily attendances to get some form of ratio. Yeah, you could do that, but there's, you know, at what point do you stop looking at data and you need to kind of ask the questions? So we've got that. We then move on to demand data. Now, we're not going to kind of dwell over this one because these are all growth measures. These will all be comparing the most recent quarter with the same time period the year before. And you'll all be well aware of where you are. I think that the only thing that I would kind of say is that the change that I've made this month is that it was just historically looking at the type 1 activity change, but actually there's been quite a significant change between different hospitals around what they're reporting in terms of type 3 and what they're reporting as type 1. And yes, I'm well aware that there's type 2 and type 5 as well, and multiple other different types as well. But we're focusing on type 1 and type 3. So this for organisation, for example, their all type has been pretty static, comparing the most recent 3 months compared to the same period the year before. But actually, there's quite a significant change between type 1 and type 3, a decline in their type 1 and an increase in their type 3. We can also split this by ambulance and walk-in. So once again, we can start to ask those questions. And I hope that I've kind of emphasised this enough, that what this dashboard is designed to do is designed to provoke those additional questions that you could potentially ask based off the back of this. One measure that I will just kind of talk you through in this particular domain is around the proportion of multiple attendances. It's called multiple different things. A few years ago, it would have been called frequent flyers, and people will probably remember that. That's not a very politically correct term nowadays. So it's either called high impact users or high intensity users or multiple attendances. And this will look at the proportion of attendances that are taken up by people who have attended 10 times or more in the most recent 12 months. We've selected 10 times. Multiple people have done different variants on that. Some people have done 10, 20, 30, etc., etc. The mind-blowing statistic is that the proportion of activity that is taken up by patients who have attended more than once in 12 months. I'm a relatively accident-prone person. I've attended my local emergency department more times than I care to remember. I should stress that they were for broken bones, so they were absolutely needed. But actually, that number was phenomenal. but we've settled on 10 times or more in a year. And for this particular hospital, it indicates that the proportion is 4% or just under 4%. The interesting thing is that this category of patient predominantly is made up of two different types of categories of patients. Patients who present with a mental health condition and patients who present with a long-term condition. So really important that we understand, once again, we understand the number, but we also understand the component parts of that so that we can ask those specific questions off the back of it. A new area that a totally new domain that has been added for this month is around time in department variation and associated metrics. Now, I'm a big believer in not necessarily, I should stress that actually, not necessarily just looking at outcome measures such as 4-hour performance. 4-hour performance is made up of component parts. And unless we understand the component parts and the variation within that, we're never going to tackle such a massive, massive subject as overall 4-hour performance. So what I've done is I've looked at some of the key areas that there is significant variation in. So the first one is around DAT2. It may be a new measure that some people have seen. This is borrowed from the SAPIT. It's been on the SAPIT for probably since the inception of the SAPIT dashboard, actually. And it looks at the proportion of patients that are seen, admitted and treated within 2 hours. So it's kind of 4 hours, but for 2 hours, but kind of not at the same time. And so unsurprisingly, organisations that do significantly well in the early identification of patients who could go to an alternative setting, such as, if they're a barn door SDEC patients, they are sent directly through to SDEC. We see organisations that perform well in DAT2 also perform well in 4 hours, and so they do kind of go hand in hand. But some of the other areas that have been seeing significant variation is the broad pathways of admitted and non-admitted mean time in department. So we've kind of illustrated that on here. Now, for this particular hospital, they are significantly challenged around their emergency department and onward flow. And so you'll see that for all of the time in department variation and different metrics that they are red, so they are in the most challenged quartile around this. We've got average time in department split by admitted, non-admitted for ambulance and walk-in patients as well. But we've also shown this, as I talked about earlier, about their mental health attendances. So you can see, for example, that on average, their time in department for a mental health patient is 706 minutes. So that's roughly around about 11.5 hours. And we've done multiple presentations and analysis for people around the fact that patients who come with mental health attendances do occupy a phenomenal amount of cubicles, and so this is really, really significantly a significant challenge for an awful lot of people. One of the metrics that Paul was talking around earlier was around crowding. The way in which we've defined crowding is the numbers of patients in the department at midday and midnight. So just using those two arbitrary time values. Now, what I've shown, a slight aside from the way in which Paul's shown it, is I've shown it in terms of a growth measure. So I've said how many people on average are in your department at midday and at midnight, and how that has changed from this time this year compared to the same time period this year last year. The reason why that's important is because if we have a look at the type 1 activity change, that actually this hospital has seen less patients coming to the department. So our demand has actually reduced. However, if we look at demand in a slightly different way in terms of how many patients are actually in our department, that has significantly changed. And what that basically means is more people or less people are coming to the department, but they are spending a greater amount of time in the department. Therefore, the amount of onward flow is really significantly challenged, and the constraints therefore contribute to that poor flow. We've got some data around hospital emergency flow measures. Hopefully, I haven't got to explain what 4-hour performance is, so we're not going to talk about those. The two that I will just mention, though, is around acuity and ABD6, just because there are a slight variant on the way in which you may have looked at acuity in the past. So acuity can be looked at multiple different ways. The definition that I have used is by looking at what happens to a patient when they're in the emergency department. And by that, I mean, how many investigations, treatments do they undertake? And that translates into the HRG that is generated for each individual patient. So there are 11 HRGs. If a patient comes in and has loads of things done to them and they generate a high cost HRG tariff, they receive a higher acuity score than a patient who has come in and had nothing done to them. And you would imagine, once again, guess what? I'm not a clinician, that if a patient has had loads of things done to them and then you've got another patient that's had nothing done to them, you would imagine that a patient who has generated a high cost HRG is more acutely unwell than a patient who's just generated advice and guidance. So that's why we've done that, because one of the kind of hypothesis that people throw to us is that the reason why we struggle with 4-hour performance is all of our patients are more acutely unwell than anywhere else in the country. And we want to try and be able to disprove or prove that hypothesis. Once again, I would stress that you do need to then go and ask more questions around some of the data that has been looked at here. APD6 stands for aggregate patient delay. Now, this is another measure that has been borrowed from the SEDIC because I think it's an absolutely fantastic measure. And it looks at the amount of time that admitted patients are in your department whilst waiting for a bed. The 6 relates to 6 hours. OK, so for admitted care, we all agree that admitted care is much more difficult than non-admitted. Therefore, we're not going to give you 4 hours for free. We'll give you 6 hours. And this is shown as a rate of hours per 100 patients. It's a little bit difficult to get your head around. But what I do is I divide that number by 100. So broadly, I'm going to get 7.3 hours per patient. So if for hospital A, somebody says, oh, I wonder how long patients spend in our emergency department waiting for a bed, it will be the 7.3 hours on top of the 6 hours. Therefore, the last time I checked, Paul, hopefully he's going to correct me if I'm wrong, that's 13.6 hours. I haven't needed Excel to do that one. So we can just really quickly identify that. I'm going to come and talk about admitted care in a couple of minutes' time because I think it's really important that we focus on outcome measures. The reason why is that bed occupancy is, has been kind of seen as the be all and end all. If you've got good bed occupancy, you get good 4-hour performance. But we simply know that that is not the case. For this organisation, though, their bed occupancy is incredibly high. We've also split the length of stay into 2 categories to show the current proportion of beds that are occupied by long stay patients, but equally how that has changed. And the reason I'll demonstrate that because an organisation that I'm currently working with, they have seen a very, very low, historically, over the past 6 to 8 months, they've seen a very, very low proportion of beds occupied by long stay patients. And you might kind of go, that's great news. Thanks very much. Let's move on. However, they have seen a significant increase in that particular cohort of patient over the past 18 months. So if you look at a relatively short time period, you might kind of go, great news, we don't need to focus on. The elephant in the room, though, is that is significantly changed over a longer time period. So actually, if that continues on the current trajectory, we might need to worry about that a little bit more. The reason why I wanted to come back to the admitted care domain is that bed occupancy just says I have a bed for a patient at the right time. But it doesn't say is that actually, do we have a problem around medicine, surgery and trauma and orthopedics? Now, it might be, as in this case, that there is a consistent problem across all 3 specialty areas. Forgive me if people are working in women and children's health and around cancer, but predominantly I've just focused on the 3 main bedded areas. For this particular organisation, not only are they struggling around bed occupancy, but all of the main areas of measurement that we have a look at for admitted care, and we're talking in terms of the proportion of 0-day length of stay patients for medical, surgical, trauma and orthopaedic, short stay, long overall length of stay, they're all significantly struggling. But actually, for the way in which we've looked at this, depending upon your hospital, you may see significant variation in this. And just because you are performing well in one particular area doesn't necessarily mean that you are performing well in all of them. And that's where we kind of, as I said right at the beginning, we want to take a much, much broader view across the whole system. Granted, there's not many measures around from a post-acute perspective, but there are a few, just so that we can try and identify areas of constraint. Interestingly, though, although there are challenged around bed occupancy and long stay patients, their weekend discharge ratio, as I've just come on to talk about, is really good. The weekend discharge ratio is, I think, is probably an underutilized measure. And what it looks at is it looks at the proportion of patients that are discharged at the weekend compared to those discharged in the week. And I'll just kind of pick silly numbers just to prove a point. So if you discharge on average 50 patients on a Saturday and Sunday, and you discharge on average 100 patients Monday to Friday, your weekend discharge ratio would be 50%. Now, you don't want that significant variation, because that's probably why you kind of leave on a Friday and everything's all rosy. You come in on a Monday morning and everything has gone to pot, and you wonder why that has happened. Well, if you don't discharge any patients over the weekend, you really constrict flow. So it's something that we kind of really historically have looked at, but I don't think really fully utilised. As Paul also talked about, we've got data from the weekly discharge collection. So we start to have a look at and compare your non-criteria to reside and your discharges on pathway 0, your proportion of discharge by 5 o'clock and your proportion discharge home against the national average. And I think that is something that we will certainly take away in terms of, should we start to put national comparators on the weekly ECIST UEC dashboard, and we value people's opinion on that one as well. So that's the kind of the first element to the dashboard, which is around the grid. I don't know why we kind of call it the grid on both dashboards, I suppose because we're not marketing people and can't think up a whizzier name than that. But let's start to have a look at some of the other areas on here. So for all of the measures that you will see, there are a two-year time series graph underneath the grid, just so you can kind of see how that has changed. And what you'll notice is there are a series of other graphs as well, and I'm not going to talk you through all of them, but I'll just kind of briefly describe them. Where you see a graph such as this, the bars will always be the national position and the dots will be your selection. So that will either be the site or the ICB that the PDF describes. Just so that you can see, for this particular example, you can see whether there is any difference around the demographic makeup of your patients in terms of the age and gender profile. So for this particular hospital, they see more of the kind of the working age groups than the national average. Is that something we need to focus on because of the type of services we offer? Is it because of the type of deprivation that we see, etc., etc.? Once again, some of the questions. The graph that I really like, which is a phrase that nobody should ever say because it does make you sound incredibly sad. And I'm acutely aware of that. And Paul did laugh, and you probably just heard that. He shouldn't have laughed. He should have been really, really compassionate towards me, but that's fine. It is this graph over here. So once again, it's kind of a similar thing. We've got 10-year age band, 0 to 9, 10 to 19, etc., etc. Once again, the bars are the national position. The dots are the particular site selected. But what we can see, and I think this is kind of terrible, I probably will use that word terrible, is that as the patient's age increases, the average time in department exponentially increases. But what we can see, particularly for this hospital, is that up to the age of around about 50, their performance is only slightly above the national profile. So you could kind of say, well, you know, that's not too bad. We just follow the national profile. But as the age of the patient increases, their performance around average time in department and the APD6 that I talked about earlier really starts to differentiate away from the national profile. So the question being, what does this particular hospital do for, or what some of the services they offer for their older patients that maybe a neighbouring hospital doesn't do? And I think that's something that we don't do enough. We don't look at organisations that are really good at some measures, and we don't necessarily kind of say, I know it's not a lift and shift. We can't just automatically take a service and kind of say, well, we're going to do it exactly the way you do it. But we should try and learn from that. As I talked about, we can have a look at the deprivation profile, so see where this particular hospital sits within the national profile. And then we can also have a look at the chief complaint. So if you really want to have a look at the type of patients that are coming to you, the age profile, but also the reasons why patients are coming to your department, to have a look at individual pathways, we can certainly have a look at that. As many comments were in the chat box, this will not be populated for all organisations, all sites, because if that is not provided in ECDS, we, unsurprisingly, can't suck that data through into the dashboard and present that in this particular type of way. As I talked about, there's lots of time series data, so I'm not going to be talking about this. A couple of things that I will just draw your attention to, though, are around graphs, such as the ones that provoke the most amount of discussion. So this one always provokes a great deal of discussion around average time in department. average time to treatment, for example. So the way in which we have historically looked at and the way in which it's reported on the UEC SITREP is the proportion of patients treated within the first 60 minutes. This shows it slightly differently. This looks at the average number of minutes from arrival to being seen by a senior decision maker over the 24-hour time period. As I talked about a few minutes ago, for me, overall performance is okay to look at. I prefer to look at variation. Why do we see such significant variation, particularly in this measure? So on the x-axis, we've got the hours of the day, and on the y-axis, we've got the number of minutes. The grey bar representing the national position, the black line being this particular organisation. And we can see it follows a similar trend. So you could kind of say, well, that's fine. We follow the national trend. You know, does it really matter? The bigger question for me is that if a patient comes at 8 o'clock in the morning, on average, they're seen within just over an hour. And you can't say that's really good because then we've got 3 hours to do a series of investigations, admit the patient, order blah, 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 whatever it is we need to do. But a patient who comes in at midnight, on average, is in the department for around about just under 3 hours. That's a phenomenal amount of variation. And I know there's multiple reasons for that. We're not going to talk about that. But is it the fact that we don't have enough cubicles? Is it the fact that we don't have enough staff on? Is it the fact that we don't have the right staff on? Is it the fact that we don't have the right beds available at the right time? Is it the fact that our SDEC closes at a certain amount of time? Understanding this data, but then asking the next series of why do we have this? Well, why is it because of that? You know, when I worked in a acute provider, we always used to do the 5 whys. And actually, it's a tried and tested methodology around really understanding what the data's saying, but why it's saying it and some of the improvement areas that can be made. As we talked about earlier, the average patients in department has been split by midnight and midday, and this will show you what has been happening for this particular organisation over the 2-year time period. So there was something quite significantly different around October. Why that was, we're not too sure, but obviously this organisation would need to work on that. Another area that I just kind of want to do now, I'm acutely aware that because it's a PDF, the interactivity around this is not necessarily there. Oh, apologies. I probably should have turned off autosave on Excel. For any analysts on the call, the perils of autosave has now come to fruition. So we'll just give that a minute to come back. There we go. I knew it would do. One of the potential interactivity aspects of this is around bed modelling. So some of you on the call, I know that I'll be familiar with the bed model that is inbuilt into here. It's done it again. Apologies for this. But what the bed model will be able to do is we'll be able to already utilise some of the data that you submit through your SUS submission, and there we go. And what it'll be able to do is it will enable us to look at your inpatient bed requirements split by a relatively high level by medicine, surgery and trauma and orthopaedic, but by elective and emergency. So it will use a relatively simple methodology to forecast how many patients are going to come in over the next 12 months and forecast their length of stay so that we can then say, right, how many beds do we need, planning at 100% bed occupancy, which of course you would never do, but it allows you to just apply some simple methodology. But the interactivity around this is that you could then say, for example, what would happen if I was able to wave a magic wand and reduce my length of stay in medicine by half a day? You click on that and it would automatically make those adjustments. Now, the interactivity is not there, obviously, because it's a PDF file. But if people would like to access in more detail, please feel free to contact me and we can go through the ECIST bed model in a little bit more detail. So a couple of other actions that we've put into the model at the moment is you can now access the quartile ranges for each of the individual measures. So this is split up into the different domains, the different measures, and the lower, upper, and median quartile ranges. Apologies that I'm aware that it has just gone black screen again. And you can also see where your selection are. So, for example, you can just have a look at any of the measures and understand different quartile ranges. You can also have a look at this. I know this was mentioned as in one of the comments around the monthly infographic. So whereas in the ECIST UEC dashboard, we've got what's been happening over the most recent week, the SAPIT infographic will have a look at what's been happening over the most recent quarter, and just put a little bit more narrative around what it has seen. So it's a little bit more of a dynamic content to kind of say that what's been happening in terms of attendances, what's been happening in terms of 4-hour performance, and a few other measures as well. Once again, the reason why I did this was because I'm a big believer in sharing, potentially oversharing of information. And I think if your organisation and people on wards, people in different departments are not aware of some of the simpler measures which go on in your organisation, I think that's a real shame, because everybody needs to understand some of either the challenges or B, the significant areas that you are performing well in, that everybody needs to be in the same boat regarding that. The last element around this is around the metric definitions, and similar to Paul and the ECIST dashboard, you've now got each of the individual metrics and some of the different definitions around that. So let me just scroll down and you'll be able to see how that one works. I have no idea why Excel is not liking me today, but that's the way it goes. So you can see here that every metric has now got the definition, what the data source was, and what the numerator and denominator is. Just in closing, and a recent kind of addition to this, is there is now a regional and an ICB view. So if, for example, you wanted to know what is going on across your whole ICB, you can now have at a glance what is going on for each of the individual hospitals within your ICB, and similar thing for regional colleagues. If you would like to know what's going on in any of your regions, you can now get the SAPIT view for all of the measures, all of the domains across both the ICB, but also from a regional perspective. So I'm conscious that I've gone through that at quite a canter. I'm going to stop sharing my screen now, and I will happily take any comments or questions that people may have.
So I think I'll just say really quickly, Chris, is that there's, again, lots of love for the SAPIT in here, and there's a lot of kind of specific metric definition questions, and I think it's probably best if we take those away, just so that, like you say, we don't say the wrong thing, and we make sure that we're getting our definitions right as well. And there was a little bit of a question around how we work out if red is high or low. So I think that you kind of touched on it right at the end there. If you use that table with which tells you what the quartiles are, you can then kind of work backwards through that logic, can't you? Yeah,
absolutely. So there's the table in there which will show the interquartile ranges, but equally the red will always indicate the most challenged. And if you want to call it the poor performing, then that's up to you. I will not. I will say that's in the most challenged. So each of the individual metrics will show you whether they are in the most challenged quartile. So hopefully that's really clear. So you can just have a look at that grid section right at the top and say, we are most challenged in X, Y, Z, and those measures. And that's the area of focus that you can kind of spend more of your attention on. So are there any other comments or questions from people? Paul and I will go through these in detail, and what I've just seen is there's a lot of people that would like access to both dashboards. We will make sure that you go on both of those dashboards. So if that's it from everybody, I just want to say a massive thank you for giving up your time on a Friday morning. Like I said, Julie, it's lovely to see you. And it's been far too long. It's been far too long. Just have a wonderful rest of your day, and I hope you have a great weekend. This also isn't the end. So once again, I couldn't stress enough, any feedback that you would like to give, any recommendations about putting different things on there, really happy to receive those. And I think Paul and I were having a conversation just in the break about that we might then do a poll about the recommendations that people have suggested and whether you would like to see that, because we can't, unsurprisingly, put on everything that you want to see, because we'll be here forever. So we might do a recommendation thing. So thank you very much for your time. Have a nice rest of your day and a great weekend.
Thank you, everybody.
Thanks, everyone.
Thank you.